Think about this, you yourself may live in one of these services one day. This presentation is divided into 6 sections. I'm going to give some background context information, and then I'm going to speak about antimicrobial resistance, infections and antimicrobial use, antimicrobial stewardship program components, and then, time permitting, I'm going to outline specific aged care resources. Important to start with some background information because the context in which aged care services are currently provided significantly impacts on the implementation of an AMS program. In Australia, 886 providers oversee 2,695 mainstream aged care homes. That's about 207,000 places. Flexible residential aged care services includes multi-purpose services that offer aged care alongside healthcare services in regional and remote areas. You might have heard in the media them talking about home care services. This is different to residential aged care services. AMR and AMS is yet to be considered in these services. Aged care workforce in residential aged care services is mostly personal care attendants. Off-site are the general practitioners and the pharmacists. 1 in 7 general practitioners work in aged care services. Medications are usually supplied by community pharmacists, and accredited pharmacists may visit to undertake residential medication management reviews if requested by a general practitioner. The new Aged Care Quality and Safety Commission was commenced operation in January the 1st, 2019, is there to protect and enhance the safety, health, wellbeing and quality of life of people in aged care. It is led by an independent commissioner, currently Ms Janet Anderson, who reports directly to the Federal Minister for Senior Australians and Aged Care, currently the Honourable Richard Colbeck. This commission is responsible for overseeing the new aged care accreditation standards that were implemented on July the 1st, 2019. Important to note is that aged care services are required to demonstrate under the standard of personal care and clinical care for the first time practices to promote antibiotic prescribing and use to support optimal care and reduce the risk of increasing resistance to antibiotics. Also, under the standard of organisational governance, they're required to, where clinical care is provided, a clinical governance framework, including antimicrobial stewardship, is to be demonstrated. There is currently a Royal Commission into Aged Care Quality and Safety underway, commenced mid-January 2019. The commissioners, after many public hearings, community forums and roundtable discussions, released the interim report last week. Has anyone here read this interim report yet? Yeah. I think for those that have read it, you would agree that the title, Neglect, is more than fair. What this report has detailed is that undeniably the current aged care services fail to meet the needs of older vulnerable citizens and does not deliver uniform, safe and quality care. Yesterday, Sarah Cosgrove noted for leading change, step 1 is creating urgency about an issue. If you look at what the report, the interim report, has listed as major issues in relation to quality and safety, what you'll note straight off is that any adverse events related to antimicrobial use, let alone antimicrobial resistance, is not noted. Now, this is concerning to me, and it's concerning because it suggests that the stakeholders that work within aged care do not understand maybe or are unaware of the urgency of AMR. Also concerning because when the final report is released next year in November, it may be well that it's not included and we miss out on funding, recommendations that go with it and funding. This report also noted that the workplace with the highest respect are poorly skilled, underpaid and under pressure to provide care. So antimicrobial resistance. Well, the studies highlight there is a significant burden of colonisation and infection among aged care home residents. There is enough published literature to do so, although sometimes the sample sizes are quite small. Most commonly referenced here in Australia is Stewart's study, Prevalence of Antimicrobial Resistant Organisms in Residential Aged Care Facilities. It found that overall rates of VRE and C. difficile colonisation were low, but that ESBL producing E. coli were detected in 14 residents. Faecal specimens were taken from 119 residents. The Australian Passive Antimicrobial Resistance Surveillance Report analysed clinical isolate data from 10 pathology services. 320 aged care homes are associated with these pathology services. If we look at graph 1, it shows between 2015 and 2017, the proportion of Staph aureus isolates that were MRSA positive was relatively consistent. Like multi-purpose services, these proportions are relatively high. Graph 2 shows that over the same period, higher than other settings, in aged care homes, there was this distinct upward trend in the proportion of E. coli isolates that were fluoroquinoline non-susceptible. Now, microbiology specimens are less likely to be taken in aged care services than other settings, and this may well explain why there were only 2,145, 2,810 positive specimens respectively. So if we talk now about infections and antimicrobial use, my take on this is I can never talk about antimicrobial use if I don't talk about infections, and vice versa. They go hand in hand. ACNAPS has consistently identified infections and patterns of antimicrobial use that may affect the safety of care for aged care home residents. In 2018, 407 facilities participated in a point prevalence survey that monitors infections and antimicrobial use. The prevalence of residents with signs and/or symptoms of infection and the prevalence of residents prescribed at least one antimicrobial was 2.9% and 9.9% respectively. This was consistent with previous years. Now, is this high or is this low? Well, if we compare the ACNAPS results with the 2016 European Healthcare Associated Infection and Antimicrobial Use in Long-Term Care Facilities study, then we find that we are lower when talking about residents with signs and symptoms of infection. But if we look at the prevalence of residents prescribed at least one antimicrobial, excluding topical antimicrobials, that we are higher. Listed here are the most common clinical indications for prescribing an antimicrobial in 2018. In blue is highlighted if the survey was unable to determine the exact clinical indication, that they might be able to tick what was the most likely body system for which the infection was associated with. Does anyone want to guess what would be the most common clinical indication in an aged care facility? Yes? UTI? Any other guesses? Respiratory over here? Okay. Okay. Well, consistently, most commonly what we're finding that's been reported is other skin, soft tissue or mucosa, so that we can't be more exact than that, cystitis and pneumonia. The indication is reported as unknown in 2018 for 6.4% of prescriptions. Now, this is not surprising necessarily because it can be difficult to diagnose infections in our elderly population. The indication was not documented for 25.1% of prescriptions, so on occasions the surveyors had to presume what the indication was. Okay, listed here is the 20 most commonly prescribed antimicrobials. Now knowing what the most common indications are, do we want to guess, maybe? Starts with C. Okay. Consistently, most commonly prescribed in our aged care services is cefalexin and clotrimazole. Just need to highlight too, in our prescribing, only 22.1% of prescriptions were for residents with confirmed signs and symptoms of an infection in the week prior to the start date. The review or stop date was not documented for 58.9% of prescriptions, and so perhaps it's not surprising that the start date was greater than 6 months prior to the survey date for 28.3% of prescriptions. Also, 36.3% of prescriptions were for topical, mostly PRN use. Antimicrobial stewardship. Our aged care services need to, and be appropriately supported to, systematically implement all core elements of an effective AMS program. Aside from residents and their families and the aged care home staff themselves, there are many key stakeholders involved with aged care services who have local, state, national responsibilities. Now, yesterday, Sarah Cosgrove also said that in leading change, it is important to form powerful coalitions. Imagine for a moment if all these stakeholders were to collaboratively work together on one single framework, how powerful that coalition would be. The Australian Commission on Safety and Quality Healthcare publication, Antimicrobial Stewardship in Australian Healthcare, recommends that if establish an AMS program in our aged care settings, that we look to refer to the core elements, the CDC core elements of antibiotic stewardship for nursing homes. This publication has 7 core elements. What you are looking at here is a draft of that framework that's been used by, let's call it cottage care. Now, there are 6 core elements, although 6 because I've combined reporting and tracking as one core element called surveillance. You don't do tracking of data unless you report it. Row number 1 is the task that we're aiming for each of these core elements at cottage care. The second row is the secondary tasks or the activities to meet task 1. And the third row is just some notes associated with those core elements. Now, if I can just highlight a few points on this framework, and the first is under leadership. Now, in the early days, I cannot tell you how many times I was told that if the general practitioners just prescribed properly, then it would all be okay in aged care. I think we've come a long way to understand that it's more complex than that, and that we need to work multidisciplinarily to address antimicrobial stewardship in our aged care services. So much so that, in fact, Standard 8 that I mentioned in an earlier slide around accreditation is very clear that ultimate responsibility for AMS in our aged care homes is the governing body, whether that's the CEO or the Board of Management, etc. The other thing I want to highlight with this framework is that we need to prioritise and implement AMS policies and practices in our aged care homes. Remember what I said, this is a new concept for them. And so we cannot possibly expect that they're going to achieve everything in one day. So to prioritise what I'm saying to the different aged care homes that I work with, let's look at what we already know. If we go and look at the standards, there is a document called Guidance and Resources that outlines activities that we might look at. The Royal Commission into Aged Care Quality and Safety interim report, whilst it didn't mention adverse events associated with antimicrobial stewardship, it did mention issues that we might be able to relate AMS to: inadequate prevention and management of wounds, poor continence management, widespread overprescribing. They talk a lot about psychotropic agents. Maybe we should tag along with them and bring it more so under the umbrella of medication management. In fact, since this report's been released, the state health ministers have discussed that medication management is a priority in our aged care homes. And then there's the 2018 ACNAPS reports that, when we looked at the data, has listed some recommendations upon which we need to act. So as a aged care home, if I look at these and we're looking to prioritise, alongside identifying our own individual needs and our own workflow, that maybe there's something here that is obvious, needs doing first. Yesterday, Sarah Cosgrove also mentioned that we aim for some very short-term, quick goals. So hopefully sitting here, you're all thinking, well, you know, how can we help? If you're external to an aged care service, how can we help? And so I think the last four components particularly are where we can help: drug expertise, action, surveillance and education. So I've just highlighted by way of example that we can look to develop, but also let's evaluate any guidelines that we develop, any standard assessment and communication tools, any educational interventions. It's not enough just to develop them and say, here you go. How do we know they're working? Surveillance is in place. The Aged Care National Antimicrobial Prescribing Survey commenced in 2015, and it's nearly there. It's quite settled. Each year we're looking to refine it so that it best works. Anything we do as external stakeholders, we need to work with the primary key stakeholders. Again, that's the residents and their families and the direct aged care staff. Okay, I cannot give a presentation unless I speak about in more detail about the Aged Care National Antimicrobial Prescribing Survey. All Australian aged care homes and multi-purpose services are eligible and encouraged to participate. Each year, the official timeframe is usually June the 1st to August the 31st. It's a single day survey and the data is submitted online. Easy to register via the naps.org.au website. There are 2 data collection forms. The facility form is completed for every service participating. The antimicrobial infection form is completed for those residents that on the survey day are prescribed an antimicrobial and or have an infection. New reports, so any facility that does participate is able to generate their own report against which they're able to do some benchmarking. The data is also submitted to AURA for their aggregate data reports. So that's working at both the local level and the national level. So in summary, the key points are the context currently very much so at the moment in which aged care services are provided significantly impacts on the implementation of AMS programs. There are studies and reports that highlight there is a significant burden of colonisation infection among aged care home residents. ACNAPS has consistently identified infections and patterns of use that affect the safety of care. Aged care services need to be appropriately supported to systematically implement all core elements of an effective AMS program. As external key stakeholders, I ask that you consider lobbying, speaking up about the urgency of needing to address AMR in residential aged care services, particularly at this point in time when the Royal Commission is underway. There's still time to be putting submissions in. Forming powerful coalitions to support aged care services, and that doesn't necessarily mean that you have to be working with groups that are AMS or in the infectious diseases space. For example, Wound Care Australia, let's work with them. Developing, evaluating prioritised actions and education interventions. Remembering at the moment there is so much happening in aged care that we've got to be very careful that we don't swamp them, because I can talk about myself. If I feel swamped, I just close the door. So I think I've got a little bit of time very quickly. First of all, I need to thank a lot of people for this presentation, but most especially the resident staff employed at those residential aged care services that to date have participated in AMS programs, NCAS, VICNIS and the Australian Commission on Safety and Quality in Healthcare. Very quickly, I think can tell you about a few resources that I would direct you to. The new infection control, the newish infection control guidelines. Again, you can't talk about AMS unless we're talking about infection prevention and control. The National Residential Medication Chart. if it's not the chart that I'm showing you, that if you're using a commercial one, that it's equivalent to this chart. The therapeutic guidelines have two really helpful tools, in my opinion: the assessment and treatment of aged care facility residents with suspected urinary tract infections, and outline an approach to managing CAP in residents of aged care facilities. Also used in our aged care facilities is the Aged Care Companion, and I think particularly the section on caring for ageing skin, non-drug and drug treatment. NCAS has some resources. We have a template of an antimicrobial stewardship policy that you might like to access. It's a Word document. You can change it to be more specific to your facility. We have some information sheets that have proven to be very popular about the interpretation of micro reports. And we've just had a newly released or published frequently asked questions about urinary tract infections. What do you do when somebody's been on a prophylactic antibiotic for a long time? VICNIS has just released this resource. It worked collaboratively with many groups: Regional Wounds Victoria, the Grampians Infection Control Group, alongside Barwon Health, QUT and NCAS. Incontinence-associated dermatitis with suspected infection, in part making some antimicrobial stewardship recommendations. Just because you've got a red bottom doesn't always necessarily mean that you need to be prescribing antimicrobials. The clinical care standard is as relevant to our aged care facilities as it is to our acute facilities. The same CDC, who have released the core elements of antimicrobial stewardship in nursing home, also has some helpful brochures, information sheets that you might like to access. And that's it. Thank you.